It's shocking and sad that your zip code or your gender identity or your sexual orientation could determine a health outcome. And I think that that's why bringing this topic to the center and focusing on it like ACS has done so well with its equity principles is important. And I think it's very consistent with the values of this organization. The vision of Corktown Health Center is a medical home for all people, and the broader vision is health equity for all. We specialize in providing care to the LGBT community.
Corktown is working to dismantle otherness in people's lives, ensuring that everybody who's seeking services recognizes, oh, there's room at the table for me here.
People are welcomed here. It's not just they're put up with or tolerated. Services are designed around them.
They're not only serving the underserved, they're serving the never served.
LGBTQ plus people often have had a history of discriminatory care or bias in health care. So they may not be getting regular preventive care. They may be avoiding care either because of those negative experiences or not being insured.
For us to win any of these fights, we have to get the people who have the loudest microphones to become a part of the conversation.
We are humans first, not categories. I think we should all care about this. People from all different sociocultural backgrounds have been affected by it.
This is simply another aspect of people's intersectionality, if you will.
We have a lot more in common than we have difference when it comes to our experiences in healthcare.
It's very important to listen to your community members, to anybody who is interested in coming together to continue the conversation and continue to enact change.
I'm having conversations that I never thought I would have in my lifetime.
This is how we create change. This is how we do something really radically different and change the game with cancer in these communities.
I believe in the American Cancer Society, and that if we're going to get there, you're the people that are going to get us there.
What a powerful video. Hello everyone, I am JC Cantu. My pronouns are he, him, and elle, and I am the Strategic Director for Diversity, Equity, and Inclusion at your American Cancer Society. And today I am honored to be your host for this American Cancer Society presentation, Speak Up for Your Health, Cancer and LGBTQ plus community. Over the next hour, 3 wonderful speakers are going to discuss health and wellness as it relates to reducing cancer risk in the LGBTQ plus community. We convened this event because cancer is a disease that affects everyone, but we know it doesn't affect everyone equally. And this program aims to help members of the LGBTQ plus community feel empowered and equipped to have discussions with their healthcare providers about cancer prevention, detection, treatment, and survivorship. While many of you are likely familiar, it's important to remember that for underrepresented communities facing unequal treatment, the cancer burden is amplified. Institutional structures can affect every step of cancer care, from prevention and screening to treatment to quality of life during survivorship. So, furthermore, research confirms that the LGBTQ plus community bears a disproportionate burden of cancer, has a higher prevalence of some risk factors, and faces barriers to healthcare beyond those of the general population. At the American Cancer Society, we strive to break down those barriers so that we can improve the lives of people with cancer and their families through advocacy, research, and patient support. Our aim is to ensure that everyone has an opportunity to prevent, detect, treat, and survive cancer. So following our 3 presentations today, we should have some time left for questions and answers, so feel free to leave any comments or questions in the chat, and we'll be sure to circle back to them at the end of the program. But before I introduce our first speaker, I'd like to share a short message from one of his patients. They wanted to share a bit about his own cancer prevention experience. So with that, pass it over to our video.
Hi, my name is Alex. I'm a long-term survivor of HIV/AIDS and patient of Dr. Blick's for over 30 years. In 2013, as part of a routine procedure, Dr. Blick performed an anal pap, which showed that I had highly dysplastic cells, or HSCL, which are considered precancerous lesions. Luckily, I found the ANCHOR study, which performs HRAs, high-resolution endoscopies. These can be done in the clinic or in a doctor's office and requires no prep. It looks at the cells and they can remove them by cauterization or by laser. By removing my HSIL, I no longer have these highly dysplastic cells which cause cancer. This is a big relief. I highly recommend that everyone have done this test routinely, either anal paps or through HRA, as often as their doctor recommends.
Alex, thank you so much for your openness and willingness to share the impact that cancer screening has had on your life. I now have the pleasure of welcoming our first guest, who, as you've already heard, is the doctor who's worked with Alex. So Dr. Gary Blick, the Chief Medical Officer for General and LGBTQ Healthcare and HIV Specialist at Healthcare Advocates International. During his career, Dr. Blick has taken on a variety of roles that underscore his commitment to a healthy world, including HIV/AIDS clinician, clinical researcher, lecturer, and humanitarian. While in medical school at the University of Miami in the early 80s, he was inspired to become an infectious disease specialist due to the increasing national HIV crisis. He completed his residency training at Yale University and Greenwich Hospital Association and went on to receive additional credentialing from the American Academy of HIV Medicine. Thank you so much, Dr. Blick, for being here with us today to talk about the importance of cancer prevention and screenings for the LGBTQ population. Please take it away.
Hey, thank you, JC. First of all, I want to thank you and the American Cancer Society for hosting this event. I remember when we first brought up the idea of this, you were so supportive of really bringing up information that the LGBTQ community can get from a forum like this. So thank you for that. And welcome, everybody. I know it's your lunchtime or wherever you are around the country. It could be your morning and your breakfast time. First, I'd like to start by acknowledging that this is Trans Awareness Week. And this is a perfect time to have an event like this talking about issues relating cancer and the LGBT community. So we all know cancer is a disease that can affect anybody, but it doesn't affect everybody equally. As JC mentioned, there are many barriers that can affect a person's ability to find or prevent cancer or survive cancer. And we deal with a lot of them in general, such as racism and poverty and housing instability, access to insurance, transportation to appointments, many things like that, limited food access. But these barriers occur because they're really deeply rooted, and they're deeply rooted in long-standing health inequities at all levels of society, and they can take on an intentional effort to address in order to have equal cancer outcomes. So this is where it really impacts the LGBT community, because LGBT people are basically disproportionately burdened by cancer, and they face these disparities and much greater obstacles to care because of many complex issues like I just mentioned. But we need to identify and continue identifying, acknowledging the disparities to help us work together to improve access to care and treatment, and therefore reduce the cancer risks. So with individuals in the LGBT community, there's less access to care in general because of a lack of inclusive health care, the underrepresentation and exclusions in clinical trials. I'm a clinical researcher. I try to recruit as many people in the LGBT community as possible, but we always find out we're really underrepresented in trials, and that's important because when a drug gets approved, we don't necessarily know how well it's going to work in the LGBT community in general. And then there's just this lack of coverage for appropriate health and cancer screenings, which I'm going to get into in the 15 minutes that I have. Furthermore, LGBT community individuals who receive a cancer diagnosis often experience these health disparities, and we'll talk a little bit about cancer survivorship during the hour. There can also be poor quality of life outcomes because of this, but for LGBT cancer survivors, there are reports of even more difficult relationships that occur, a very low satisfaction with the cancer care and treatment they get, and in general, just poor overall health outcomes and everything. So the factors such as distrust in the medical team, this can have a huge impact in the LGBT community. And once again, we have to disclose our gender identities, our sexual orientations. It's really important to discuss this and divulge this because we want to receive appropriate care and services because we have specific issues that I'm about to address that we need to deal with. And this disclosure obviously does not always happen. There's a lot of, discomfort with providers. There can be doctors' biases, healthcare providers' biases that are brought in when a patient comes in there and acknowledges they may be part of, for instance, the transgender community, or if they're lesbian or gay. And people have experienced, really unpleasant, sometimes even disastrous experiences with stigma and discrimination when they go and seek care. Obviously, this leads to potential mistreatment. It leads to layers of fear in seeking additional care and sharing their concerns. It was even brought up through the National LGBT Cancer Network that many LGBT cancer survivors report that their partners weren't permitted, even in the emergency department, no less, in care with them, leaving them alone and then frightened. So let me address some of the cancer issues, by members of our community, starting off with first lesbian and bisexual women. Well, lesbian and bisexual women are more likely than heterosexual women to have poor physical and mental health to begin with. This is noted. They may have more asthma, diabetes. They may be more overweight, more inclined to be smokers and drinking excess alcohol. Well, with all those things, there's a greater risk for breast cancer, as well as other cancers linked to these risk factors, including lung, liver, colon, esophageal cancer, cervical cancer, and we're even going to talk about anal cancer like Alex just presented to you, because that doesn't only affect gay and bisexual men, it affects everybody. Okay, so I'll get into that in a few seconds. But gynecological cancers in the lesbian and bisexual women community can also be increased just because of delayed childbirth, if it's until after the age of 30, or for not even having biological children at all. As far as gay and bisexual men, well, it's been known that African-American gay and bisexual men have the lowest use of prostate testing and therefore an increased incidence in prostate cancer with much poorer outcomes. So we can really start there. Everybody, gay man, a bisexual man, a transgender woman who will then still have their prostate should get a PSA test done by a doctor on an annual basis, at least after the age of 50, if not earlier, if there's a history of prostate cancer in the family. A PSA is a prostate-specific antigen test. It's a simple blood test. It can help you monitor whether there's a change from year to year that would assess your increased risk for having prostate cancer. It can even pick up prostate enlargement and prostate infections. But prostate cancer is one of the most common cancers in men in general, and then gay men with prostate cancer have some additional societal and sexual challenges that are rarely addressed unless you're into seeing an LGBT healthcare provider who can definitely address the issues that are associated with this. For example, prostate cancer treatment can have some distinct effects on gay and gay sexual behavior and relationships, and many providers may be uncomfortable to talk about these things to begin with. Alex mentioned to you something about human papillomavirus, HPV. Very, very common in general, but much more common in the LGBT community. This is a virus. There are very high-risk strains of this virus that you may be familiar can cause cervical cancer in women. And that's why women have cervical pap smears done on an annual basis. Well, they're also responsible, and this is an up-and-coming field, in causing anal carcinoma. You don't even have to be part of the LGBT community to worry about this. I come from the days, I call it the Cretaceous era, but I come from the days of the real Charlie's Angels from the 70s with Farrah Fawcett Majors there. And Farrah Fawcett Majors, a heterosexual woman, died from anal carcinoma. She had abnormal pap smears, and nobody understood that even if you have an abnormal cervical pap smear, that HPV virus can migrate to the anus. She swore that she never had anal sex, but that would be one high-risk area to cause HPV to be transmitted to that area. But in general, the virus can just migrate to the anus. So even women, if you've ever had an abnormal pap smear, hopefully your gynecologist will also do an anal pap smear. If they're not comfortable doing that or don't know about it, you can find a doctor that does anal pap smears, and maybe they're going to be a member of the LGBT community, but feel comfortable to them if they know about this. The HPV virus spreads through receptive anal intercourse, as I mentioned, but in the gay community, it can be found as often as 50 to 65% in gay men and without HIV, but those who are HIV positive, it may be up to 95% present. And it's a very simple, inexpensive anal pap smear test, just like women have. It's a Q-tip that goes in, we swab the anus, come out, and we send it off not only to see if you have HPV, high-risk types that can cause anal cancer, but also to see if you already have changes in the anus that are at risk for causing anal carcinoma. Unfortunately, very few physicians perform this anal screening, and very few physicians offer these anal pap smears to gay men, no less heterosexual women, no less lesbian or bisexual women. Therefore, anal cancer rates are very, very high, and they're actually much higher than they were in men than they were in women before routine pap smears became present. And what you need to know about this, in the past, if you had, say, genital warts or positive HPV, you go to a surgeon and they cut it out. Now we have what Alex was talking to you about called HRA, or high resolution anoscopy. It's very simple. This can be done in a doctor's office with a skilled anoscopist. They basically just put a plastic anoscope in, they numb you out with a little lidocaine, and with little high resolution binoculars that increase the magnification by 20 to 25 times, they can see the presence of viruses by just putting a little liquid in there, and it lights up white. And you can also put a little iodine in there, and you can see potentially abnormal lesions, which then they can take biopsies for, send off to pathology. If there's a high resolution, a high grade inflammatory lesion there, then right through the same scope, they can obliterate those lesions and help prevent anal carcinoma. Alex mentioned the Anchor study. It was proven by doing HRA and treating these lesions, you're much lower at risk from getting anal carcinoma. The question is, do you have a high-resolution anoscopist in your area? And you can simply Google HRA or high-resolution anoscopy in your city or in your state and find out where these anoscopists are located. But don't forget, even if you're a woman with an abnormal pap smear, you're at risk for getting anal carcinoma, just like I mentioned. So don't forget, it's a very, very important screen. Now, as far as our transgender and gender nonconforming and non-binary people, they sometimes face even greater barriers to quality health care, coupled with the dearth of research on their cancer risk and experience, but they're just not well represented in clinical trials. Obviously, they face discrimination by healthcare providers, many of whom also lack the information about trans bodies and the transgender person's healthcare needs. But 1 out of 4 transgender people actually turned away from their healthcare providers when they go to seek help. The uninsured rates are highest amongst transgender people. Even those with health insurance can face difficulties in obtaining the appropriate cancer screenings. A transgender woman, for instance, may be listed already on her insurance as being female, but she still has an intact prostate gland that does need to be monitored on an annual basis when she gets to the age of like 45 or 50, and we can't forget that. The same thing in a transgender male, they still have a cervix present, unless they've had a full hysterectomy and have gone through all of the sexual changes and stuff. They need to have cervical cancer screening done on an annual basis to make sure that they don't get cervical, and as I mentioned, even prostate cancer. So this is really, really important to make sure that even in transgender individuals who now, even though they may be transgender males, still may identify now as a cisgender male. We cannot let them forget, and we can't forget, that they still need all the other screenings to make sure they don't develop cervical and or prostate cancer. And far too little is really known about the cancer risk of transgender hormonal use. So research is really essential for this. And we need to do breast screening and everything like we normally do for anybody that may be taking hormones, and especially these kind of daily hormones that are not countered, like let's say with progesterone. And not to mention, transgender people have extremely high rates of homelessness, insurance inequities, poverty, as well as increased smoking, drinking, as well as increased HIV, which in itself carries its own cancers associated with that, now that HIV patients are living to the ripe old age of 80. So we've just got to be very well aware of all these different cancer risks, and that there's screenings out there for everything. So I'd like to pass it on now to our next speakers, but we'll take some questions and answers at the end of the end of the presentations. Thank you.
Wow, Dr. Blick, thank you so much for that important life-saving information. I think as we're talking about inclusive healthcare for all, right, and ending cancer as we know it for everybody, we need to make sure that our transgender, gender nonconforming, queer, LGBTQ plus siblings are all included in that conversation, right? So I want to thank you and organizations like the National LGBT Cancer Network and Centerlink and your colleagues for providing us with the support and collaboration to ensure that we are putting forward things like, our LGBTQ people and cancer fact sheet for healthcare providers and cancer care for transgender and gender nonconforming people fact sheets and information to educate healthcare providers and ensure that we're able to close that gap, address social determinants of health, and that inclusive care is delivered to our transgender, gender nonconforming, LGBTQ plus siblings. So I really appreciate that, Dr. Blick, and more to come in our Q&A session. Again, please leave those in the chat and we'll address them near the end of the program. So speaker is Dr. Dizon. Dr. Dizon is a medical oncologist and professor of medicine at Brown University. He is the director of the Pelvic Malignancies program and Hematology Oncology outpatient clinics at Lifespan Cancer Institute, the director of medical oncology and the oncology sexual health program at Rhode Island Hospital, and the head of community outreach and engagement at the Cancer Center at Brown University. His research focuses on enhancing survivorship and social media, and he sits on the board of the National LGBT Cancer Network. Thank you so much for being here, Dr. Dizon, to touch on the LGBTQ plus cancer experience and certainly opportunities for improvement and furthering equity for all. With that, Dr. Dizon, the floor is yours. Thank you.
Thanks so much for having me, and I'm really pleased to be here, and I'm congratulate the ACS for taking this on as well. I'm just going to build on a couple of things that was mentioned before. First of all, I think everyone who's walking into a cancer clinic is oftentimes prepared for hostility, and that's not because of a cancer diagnosis necessarily. It's because there is an experience of hostility that this community, our community, has experienced. If you look at some of the literature, if you just look at the LGBTQ population, those figures are almost as high as 1 in 10 of us have either been turned away for healthcare, have not had our partners recognized as family, and even the experience of being spoken to harshly. Unfortunately, that's much higher rates of hostility for our transgender friends and colleagues, where it's almost triple. So the experience of being touched inappropriately, for example, is up to 30%, and being intentionally misgendered, almost one in four have had that kind of experience. And all of this, comes into play, particularly when someone is hearing a diagnosis of cancer for the first time. It's a little bit more complicated insofar as most centers are not asking about one's sexual orientation and gender identity in a report that was put out just 3 years ago. Asking people who worked at comprehensive cancer centers whether or not they were, asking their patients or collecting information on people who are coming in about sexual orientation, only 1 in 10. If they were collecting information about sex at birth, it was 1 in 5. And in terms of gender identity, it was 1 in 5 as well. So the vast majority of those of us within our communities diagnosed with cancer remain invisible. Now, the good news is that there is an appetite to change all of that. When we have surveyed clinicians working in comprehensive cancer centers, they want to understand more about the needs and how best to care for an LGBTQ population. And up to 6 and 7 out of 10 folks who work in these centers would be very willing to be listed as an LGBTQ friendly provider. But there is still a lot we don't know because we are not collecting data on sexual orientation and gender identity. I was part of a group who looked at medical records spanned over 1.3 million people in a database. And our job was a simple one. We wanted to identify transgender people within this database. We used selection criteria as, for example, someone listed as female, but was being treated for prostate cancer. And with all of that, our catchment rate was less than 0.005%. So we were not able to intuitively, using AI methods, find transgender patients within a database of 1.3 million. And this is important because the way I administer chemotherapy depends on what someone's gender is. It's how we dose chemotherapy safely. It's how we monitor your heart, your kidneys. And in fact, there's data now that's showing, compared to men, women treated with therapies for cancer experience more toxicities. Now, what about those people who are trans? Do they experience the same level or risk of toxicity? We don't know. And what about the experience of gay men versus straight men? Is that experience the same? Again, it is an unanswered question. Now, the more significant parts, because we have this blank box on how people undergo cancer treatment, the impact of cancer treatment on their survivals, for example, the impact of cancer treatments on their post-cancer life as an individual, as part of a community, as part of a couple. Again, we do not know. But there was this attempt to try to understand it better. And it was called the OUT survey. And it was spearheaded by the LGBT Cancer Network. It was web-based, and almost 3,000 people participated in that survey. And what we learned was 30% of those responding to this OUT survey were being treated for more than one cancer. So it might be that it was a very select population, but that figure is alarming, and we need to understand that better. We also know from this survey that up to 40% are also living with a disability. The good news is that when our community was surveyed, 90% felt they were satisfied with the treatment experience that they got at the centers they were a part of. But there were severe gaps that I personally found alarming. The most important that was asked in the survey was, were you asked about preserving your fertility? Now, it's important to understand that this is a huge initiative within cancer professional societies. We want to make sure anyone who is of childbearing potential is informed about their options to preserve their fertility and preserve their options to become parents later on in life. Now, we are not doing a great job in the general population, but when you looked at what the experience was of people in our community, they were asked, did you have a discussion about fertility? 18% recalled such a discussion. So over 80% were not offered fertility counseling or recalled being offered fertility counseling. And the reason that that's important is because among people treated for cancer at younger ages, a huge component of regret is not being able to have children and not being informed of their options. So again, hard to read into why these folks were not offered fertility counseling, but I fear that it might be a bias, implicit or explicit, but a bias against members of this community living and dealing with cancer. The other things we learned about this is that we want resources. We want resources that are specific to our communities. We want resources where we see ourselves in the post-cancer experience, or even as one is undergoing the cancer experience, we want to see our communities reflected. And that was important in almost 60% of people. It also does not exist. So again, this is a rallying cry for institutions to develop such resources for people in sexual and gender minoritized communities. So what I tell my colleagues is that it's important that we understand where our biases are, because sometimes those biases lead to these disparities in care that was just discussed. I will tell you one of the more frequent ones we hear about is that lesbians do not need pap smears. And the reason is because they're not having sex with men. Well, you just heard that cervical cancer is common in bisexual and in lesbian women, and that they should be getting screened for HPV, because HPV does not discriminate by sexual orientation, and is the same as true for anal cancer, which it would be a misperception in my colleagues if they felt it only happened to gay men. Hence, it's not important if you're not gay and you're not male, which again assumes that all gay men are having anal penetrative intercourse, which is also a terribly incorrect assumption. There is an assumption that LGBTQ people don't want children, when in fact, there's up to 4 million children have at least one LGBTQ parent in this country. So again, it's important that we understand your perspectives about life and also about how you want to be treated. And it's important that we break the association between cancer and gender. Very recently, when we wrote clinical trials for breast cancer, we specified women with breast cancer or females with breast cancer, or this trial is open to men with prostate cancer, when in fact, cancer does not have a gender. That if you are a trans male with your ovaries, your uterus, your cervix intact, you can get cancers of the ovary, uterus, and cervix, as was already mentioned. So it's really important that we try not to make these generalizations about who gets cancer and who does not. The gender and cancer relationship is one of the things that I and many people interested in this space professionally are trying to break. And I think we are making progress, just so everyone listening knows. Finally, I think it is also important that you understand this is a work in progress, that we are dealing in a situation where 8 in 10 centers are not collecting SOGI data, but the movement has started. The National Academies for Science, Engineering, and Mathematics did put out a report on a collection of SOGI data across the NIH, and they're recommending that be done. And it has to be done because, as stated, there are many questions we do not know about the experience and the outcomes for the LGBTQ community when it comes to cancer and cancer therapies. There are many biases against the care that should be provided with equity. And I think this is a space that we need to partner with communities and centers that provide healthcare to make this happen. It starts right at the point where you enter a center, maybe not even the cancer center, maybe it's the institution itself. And it's something that needs to be applied in what's called an implementational scientific way, which means talking to stakeholders, not only communities, but also the leadership within institutions, the people who park your cars, the people who check you in, nursing staff. This is not something that can be solved by solely working with your physicians and your advanced practice providers. What we need to provide this level of empathic care is for everyone to understand why it's important, and let them know that this is, it really is a part of humanized healthcare. And finally, I think the biggest thing is that we need to be brave enough to disclose our sexual orientation and gender identity, which is not a small matter, especially when one recalls the risks and the lived experience of hostilities. And this is not something that's lost on those of us in trying to advocate for LGBTQ equity, because in the cancer experience, one doesn't just meet a doctor that's going to take them through the entire experience. You might need a surgeon, a medical oncologist like myself, a radiation oncologist after that, a palliative care specialist, a social worker, a nurse navigator. And imagine if at all of those points you are continuously having to disclose your sexual orientation and or your gender identity. One would think that the medical record should prevent that. But in reality, people have had the experience of having to disclose multiple times. And at each point, that disclosure has the risk of being treated unfairly or inappropriately. So again, I think at the end of the day, this is something that we're going to have to learn from each other, that physicians and clinicians are very interested in learning how better to serve our communities, but we also have to teach them and be brave about who we are to the community itself. So with that, I'll turn it out back to JC. Thank you very much for having me.
Oh, Dr. Dizon, it is our honor to be here with you today. And thank you so much for dropping so many great nuggets. Throughout our presentations, I've been taking notes here and underlining things, and always such a pleasure to work with our National LGBT Cancer Network. And thank you for your service there. But, some of the things I just want to call out for our audience here is, 30% in the Out Cancer survey reported as having, right? Another really interesting piece of data that you shared is up to 4 million children have an LGBTQ parent, right? These are millions of people across the country that we are serving and that need this humanized care, especially love. Cancer does not have a gender. Cancer does not have a gender. Makes me think of we're saying, if you have it, screen it, right? If you have a prostate, if you have a cervix, screen it. So definitely getting me thinking about that. And then improving the SOGI data, improving collection and understanding our constituency. I'll say, as an organization at the American Cancer Society, from working with the National LGBT Cancer Network and other providers such as yourself, Dr. Dizon, we're on our journey as well to improve that. So thank you for calling out that this is a work in progress, right? And feedback and collaboration is essential to ensure that we are serving people in a humanized way. I also want to plug the Welcoming Spaces training that the National LGBT Cancer Network is provided, and I believe it's up throughout this year for everyone to access that is involved in any aspect of the healthcare and delivery experience. So whether clinicians or front desk folks, or as you mentioned, the folks who are checking the car, anybody who's involved in that cancer delivery or that experience in the healthcare center. So thank you so much, Dr. Dizon. I'm really looking forward to our continued conversation at the end of this session. But I would now like to welcome our next speaker, Nandini Choudhury. Nandini is a licensed social worker with a master's in public health and is a reproductive health equity specialist at Fenway Health. Nandini joined us for last year's Speak Up program, and we are so thrilled to have her with us once again. Nandini is here to talk briefly about her work and the critical importance of personal health advocacy. So with that, Nandini, I know you're no stranger. You're a friend of the broadcast. Thank you for being here. Please take it away.
Thank you so much, and welcome everyone. And thanks so much, ASCAM, for having me here again. It's always a pleasure to keep discussing advocacy and health equity around cancer care for LGBTQIA+ folks and BIPOC communities. So I'm going to continue the conversation around cancer and wellness in the LGBTQIA+ communities and BIPOC communities. And some of the objectives of my time here will be to identify some of the barriers to accessing cancer care for LGBTQIA+ folks and BIPOC populations. Also discuss strategies to increase research and clinical studies for these communities, and also summarizing key priorities in advocacy and community engagement for cancer care for these populations. And I want to center this conversation about understanding the relevant historical basis for reticence shown by BIPOC and LGBTQIA+ folks transgender and gender diverse communities with overall healthcare. I think these populations are wary of the healthcare system and receiving care, including cancer care, as Dr. Dizon and Chris mentioned, because of the historical trauma and the hostilities in healthcare delivery. It's important to recognize that historically there's been ethical troubled research conducted on communities of color and LGBTQIA plus communities, appropriation of bodies and body tissues for non-consensual research, and just overall racism and discrimination within the healthcare systems. And historically, there have been many instances of medical abuse towards BIPOC communities and LGBTQIA plus communities. Some examples being James Marion Sims' gynecological experience on enslaved women with Anarcha, Lucy, and Betsy, the Tuskegee syphilis study from 1932 to 1972. So that's not too long ago. And in the 60s and 70s, thousands of Indigenous women were sterilized without consent, and a California eugenics team forced and coerced thousands of sterilization of women and men of Mexican descent in the 20th century. And then, the ongoing racial bias in pain assessment and treatment, the recent hate crimes against AAPID communities, and the anti-Asian sentiment with the pandemic. And also, given as this is Trans Awareness Week, the importance of understanding the anti-trans and gender diverse bills and policies, and also the inadequate education of trauma-informed language for healthcare providers who work with trans and gender diverse clients and patients. I would say that there are efforts to encourage folks to be better in how they deliver care, and also encourage BIPOC and LGBTQIA plus communities to access healthcare, including cancer care. And it's one of the things that I like to talk about is that one way to build trust and bring education to the field of healthcare is understanding the historical impact that BIPOC and LGBTQI plus folks have had in the healthcare field. So, for instance, you have Susan Lafiche-Picotte, who was the first Indigenous female physician. You also had Dr. Lewis T. Wright revolutionize the smallpox treatment. We currently have Dr. Vivek Murthy serving as the Surgeon General for the United States. We have Dr. Rachel Levine becoming the first 4-star officer to serve in any of the U.S. 8 uniformed services. And close to home, we have Dr. Scout, who's the executive director of the National LGBT Cancer Network and the PI of both the CDC-funded LGBTQ tobacco-related cancer disparity network and OUT, the National Cancer Survey. And then, of course, with this month's midterms, we're seeing LGBTQIA plus and BIPOC folks taking positions of power. So, we have Massachusetts' very own Maura Healey as our first lesbian governor and Andrea Campbell as our first Black attorney general. And you see Wes Moore as Maryland's first Black governor and Maximo Alejandro as a member of Congress for Florida. And I honestly think if we teach and acknowledge the contributions made by these folks, scientists, healthcare providers, politicians who uphold health equity for communities of color and LGBTQIA plus communities, it's the first few stepping stones to building trust with folks when they look at medicine and healthcare delivery. And, it's not a substitute for reforming America's healthcare system and delivery mechanisms. Healthcare delivery, and I would include cancer care delivery in this country, is still inequitable for BIPOC and LGBTQIA plus communities, as we've heard from the previous speakers. In terms of insurance coverage and the lack thereof, just overall access to care, inadequate and traumatic care from healthcare providers overall. So we have to reform all of this in order to really truly want to make a real and significant steps in addressing health equity. So there's some take-home points that I want to share with you all as we near the end of my speaking portion for today. One take-home point is support. So, for example, support gender-affirming and trauma-informed language and provider knowledge that can really improve patient experience. Health surveillance. The same health issues that impact cisgender health and cancer care impact LGBTQIA+ and BIPOC health and cancer care. So again, encouraging folks to participate in cancer care research and being transparent in how that research is going to impact their overall health. And then planning ahead, routinely discuss cancer screenings and introduce studies that focus on improving cancer care for LGBTQIA+ and BIPOC folks. And the last thing I will say, and I know the folks here will share these resources later, but just some resources to share with you to continue this discussion around advocacy and providing access. There's the 2022 US Trans Survey, which is amazing. So the survey closes on the 21st of this month. So there's still time for folks to fill it out. There's also the National LGBT Cancer Network, the Ellie Fund, and some writings and books that I wanted to share with you all that touch on a lot of the topics that I spoke about today. One of my favorite books, Medical Apartheid by Harriet A. Washington, is a fantastic educational read. The Cancer Journals by Audre Lorde, of course, and Beyond the Gender Binary and Your Wound and My Garden by Alok Vaid Menon, where they discuss the ability to step out of the binary lens and really take an educational lens to what it means to go beyond the binary and understand the pain and suffering that transgender and gender diverse folks have to go through on a daily basis. So I'll stop there, and I look forward to the Q&A session to continue this conversation.
Oh, well, thank you so much, Nandini. Again, following our theme of providing some really great topics for consideration, and especially in the advocacy space, right? I think we can definitely sit with and celebrate. I think it's important to celebrate and acknowledge the wins for representation of BIPOC and LGBTQ folks, especially in our elected offices, right? Folks making decisions for us and furthering these. So thank you for that. I'm a big fan of celebrating the wins that we have to fuel us, right, for the journey ahead, for more progress. Although, and we certainly know that more progress is needed. And then additionally, thank you for the resources. I can say some great content that I've visited myself. And I will just plug the Beyond the Gender Binary. I will say I've read that multiple times and come back to it. It's an easy read, so folks, definitely it's accessible. Please do check that out. So at this point, as Nandini said, we're going to go ahead and move on to our Q&A portion of the program. Now that we've heard from our three incredible speakers, I'd like to welcome all of our amazing panelists back into the conversation today, so that way we can hear a little bit from folks in the audience. So, panelists, one of our first questions that came in is, how can we encourage healthcare organizations which might be hesitant to collect SOGI data to start doing so? Who would like to take that?
I'll start off by saying that, our electronic health records don't necessarily even address this problem. So that has to go back to the basics of the development of these programs. A hospital-based one like Epic does do that, but those in private practice that can't afford those kind of huge electronic health records cannot. And we've encouraged EMDs, our electronic healthcare record provider, to start opening up those fields. So now they have, a birth at gender at birth, current recognition that we can put in there. They're starting to adapt these things, but we just have to keep encourage them that we really have to adapt these programs to really take into account all the aspects of the LGBT community.
Yeah, and I just expand on that. Absolutely correct that the larger EMRs to meet certification had to have the ability to collect SOGI data. That was not accompanied by a mandate to collect SOGI data. And it's actually even, I'll be completely honest, we are not doing it at the Lifetime Cancer Institute because we're trying to be very thoughtful. Again, when I mentioned implementation, it becomes it's a bigger issue than just the collection. It's about who is collecting the data and do they understand why they're collecting the data. And again, we want to make sure that it's done in a very respectful and private way, realizing that the data may be, you might get some questions as to why exactly you're asking. And I'll share an anecdote real quick, is that I had been taking care of a person with metastatic breast cancer for quite a while, always came in with her friend, never asked who this friend was. And when I realized, after being, actually only after being involved in this advocacy space, I made it a point to ask. I never once asked about your relationship together. I know you are together. Just clarify for me, do you consider yourself, gay, lesbian, straight, or something else? And it was the most out of the blue question she had ever gotten after working with me for like a year. And she was like, "Why are you asking me this? I don't understand why you're asking me this now." So again, there's a sensitivity to this. There's a way it's being asked, whether or not it should be asked directly as I did, or if it should be given to them to answer in their own time. Part of the things for transgender patients, Nandini and I have talked about this, is the whole idea of an anatomic inventory. If I was sitting across someone and was forced to ask someone, I know you're a trans man, have you had these removed? What about that? What about this? That is an uncomfortable thing to me to imagine. And I've heard from trans patients that itself can be very triggering. So I think there are questions that are best asked, before you come into your visit. Here are some questions, for you to ask so that it's part of your record and we know how to guide you. But I think to answer this question more directly, I agree with what already said. You might have the ability to do it, but we have to empower the staff to do it. And to do that, it starts with education.
And I also would like to, maybe I don't want to be too harsh about it, but if you can't adapt your system to meet the needs of the LGBT community, maybe you're not seeking the right LGBT friendly healthcare center, because it's very easy to adapt these. We right there in our demographics. We have whatever name you prefer to use right now for your chosen name at this point. Plus, we have pronouns in there. So if you can't adapt a system like that to respect that, then you're not creating that warm, safe, friendly environment for people to come into where they can really feel secure and feel like family in there. So it's just something to say that if you can't adapt it, maybe you haven't adapted or don't want to adapt it. And there's ways to do it, even in less expensive systems where it's not required.
Yeah, and I will add that understanding that EMR software is very expensive, especially for private practices. That one of the innovative ways that I've been a part of is creating intake forms that patients and clients can fill out themselves, and understanding that it's okay if they opt out to fill in that information. If they really do not feel like filling that information out at that time, it's okay to allow them to do so. And just let them know that if they want to change their mind of disclosing SOGI data, that they can do so at any time that they feel that they want to. And just, having a transparent conversation to say, look, the reason why we ask you this is to make sure that we as a healthcare team and we as the healthcare system want to deliver the best care possible with the information that you give us. But again, it's perfectly acceptable to have your patients and clients walk away with saying no to many questions because of that safety concern.
Agreed.
Where the data is going.
Absolutely. Thank you, all three panelists, for those amazing insights. So from intake forms to adapting the EMR to being really thoughtful and intentional with explaining why this data is coming, how we're going to use it, right? Assuring folks, maybe dissuading from thinking about, hey, this is not for gatekeeping. We're here to ensure that we can serve you in the best manner possible and tailoring that care. So thank you all so much for that insight. We have a few minutes left, so I want to maybe get to another question here. And Nandini, it looks like we have a request for some book recommendations, so folks will be looking forward to that in the chat as a follow-up. But additionally, panelists, maybe you can speak to a question that came up about signage or ways to communicate that your facilities, that your centers are a safe space. Any specific suggestions for how your organization does this, and maybe some best practices to share with others?
Well, let me start. I mean, I think, it can't be just about the rainbow flag being everywhere. Okay, that just doesn't work these days. Having a gender non-conforming bathroom says a lot. Having your posters in the magazines you display not being so heteronormative or heterocentric is also a very subtle signal. I find when I'm traveling through airports these days, I feel much more comfortable if I see a gender non-conforming bathroom is available. That says a lot about an organization. But yes, I mean, I think, having people display pronouns as part of their badge goes a long way, probably much more so than, I'd say, every student across your entire organization wearing a rainbow flag. And then, quite frankly, it just comes down to one of the things we're actually thinking about doing, and I'd love to hear from the other panelists, but we're actually considering naming someone as a navigator specifically for the LGBTQ community. So if someone comes into our system, because we have to recognize that, in my entire 20 plus career in oncology, taking care of a transgender patient within our practice is going to be something rare, for an individual practice. So, it's about resource dedication. But just as we have, and I think Nandini really mentioned this, we have navigators for Latinx patients who do not speak English. Okay. And we have the same thing that meets our communities that are underserved. This is one of them. And so having a navigator that does the outreach and can walk people through the practice and can actually do the problem solving as well as stave off the conflicts can do a lot.
Yeah, I think that's a great idea. And, if you're coming to the Fenway or you're coming here to Healthcare Advocates International, we don't necessarily need a navigator because we are primarily all LGBTQ, most of the time. And that also brings in the heterosexual population and knows we're friendly and accepting of the LGBT community, by the way. But also bring up the point that when you come into the office, your first interaction is at that front desk. So that front desk person really needs to be the most sensitive there. And if you did the intake sheet where we also have pronouns in there, our front desk person says, oh, from your intake sheet, I see that you prefer to be addressed by they. Is that correct? Or if they failed to mention that, I see that you didn't want to fill in this section about pronouns. Maybe that's because you forgot. Would you like any specific pronouns for us to address you when you're getting your health care? In other words, very sensitive ways to go about it and addressing it. And that first approach, that first contact at the front desk is critical for that.
I'm so glad you mentioned that because I think it's a understated concept around employee training for front desk staff, and it's I'm chuckling because it just goes unspoken, or it just goes unrecognized in terms of like where employee training needs to happen, and that front desk training and that patient service staff training goes such a long way, especially when you are addressing the signage in ways that you communicate well and you communicate under trauma-informed care. I actually would encourage folks to look at Fenway Health's website. I think that's a good example of how we aren't just blaring out the rainbow pride flag as a signifier, and how we've actually broken down our services so that folks can see transparently what services are being offered. And, you know, if you walk into our clinic, we do have gender nonconforming facilities as well. And then even in the department that I work in, which is the reproductive health department, we actually used to be called the women's health team. This has been an ongoing rebranding project of mine to take that binary term and make it more inclusive and just us be called the reproductive health and OB/GYN department. And that made a huge difference in terms of signage and communication to our communities. And we rebranded our webpage, our links, and it just made folks feel safer and better recognized when coming into our space. So something to think about when you're looking at like Marcom and communications, and especially your external communications that community members can see.
You guys are a model of excellence when it comes to treating it. Been there from you since the days you opened your first doors. Yes, congratulations.
Thank you.
Certainly, and I want to echo that, and thank you, panelists, for what I think are very practical ways that people can practice inclusion every day. That aren't as big of a lift as people think they are, right? But sometimes getting them to that point to see that is the biggest hurdle. So thank you all so much again for highlighting those. Unfortunately,
can I just say one statement before we go? This is for everybody in the LGBT community. You need to be empowered to get your own information and help get your best care. So one of the purposes of today's session was to empower you with information so that you can go in and find out where you're most comfortable and that safest experience for you. So just remember, it's all about you. The education's there. You can Google it anywhere. But in finding the best healthcare, you need to be the ones empowered to do that. And if you're not comfortable, you go to the next place.
Thank you so much for that, Dr. Blick. You read my mind. Can we get just really quickly one sentence as well from our other panelists on how folks tuned in today can really speak up for their own health and wellness?
I think it goes a long way to, I know Fenway Health has a patient service line and a med call line where patients and clients can phone in their critiques and feedback on services. And that makes us that makes us do better on the work that we do. And it actually goes a long way to receive those feedback points so that we can address the work internally, so that externally we do a better job. And that is I think an understated form of advocacy for yourself is when you deliver those feedback points to healthcare providers and overall health services. I mean, that's how we found out that we needed to change our branding for a lot of our departments at Fenway.
Thank you so much. Dr. Dizon?
No, I would actually just say that just remember that when you're seeking care, we actually work for you,
right?
Not the other way around. So you should, the respect that you show to your clinicians is the respect you should expect back. And that no one should be in a situation where they feel stuck. So if it's a second opinion, if it's a direct, I would like to see somebody else, that is your right. And I think you should exercise it.
Thank you so much. 3 really salient, direct actions that we can take to speak up for our health in the LGBTQ community. So thank you so much to our esteemed panelists here today on behalf of the American Cancer Society. Thank you for joining this important discussion around cancer's effect on the LGBTQ plus community. And thank you to the amazing team that's brought this wonderful event together. So we know that addressing health inequities in cancer outcomes requires all of us, and we hope that this program has given each of you a better understanding of why you should speak up for your health and how you can become a voice in promoting wellness within your own community. So we welcome everyone to learn more, to encourage your family, your friends, your loved ones, those around you to become their own health advocates, and be sure to talk with your healthcare provider about what cancer screenings are right for you. You can also learn more about the American Cancer Society and our advocacy affiliate, the American Cancer Society Cancer Action Network, call them ACS CAN, by visiting cancer.org and fightcancer.org. And if you joined us for today's program without registering, we invite you, please visit the link in the chat to register. By doing so, we can notify you of our future programs, and we'll be able to share any relevant resources as they become available. So again, a big thank you all for joining our program today and for your support in ending cancer as we know it for everyone. Thank you so much, and be well.
Thank you.